I'd like to welcome and thank Joel Venko, Chief Applications Officer, Clinical Systems and Technology for Boston Medical Center, for the presentation today. And Joel, I think you can begin whenever you're ready.
Thank you, Shelley. Good afternoon, everyone. Again, my name is Joel Venko. I'm the Chief Applications Officer at Boston Medical Center and Director of IT. My team basically oversees all of the technologies and applications and devices at Boston Medical Center, including the interoperability and integration technologies. I'm going to talk a little bit about the information exchange, which falls under my purview. So today, basically, I'm going to talk about our referral process solution and what we did to really solve the problem that many of us have in the hospital industry with regards to managing our referrals. And what BMC has essentially done is work on developing this referral process or system to really align physician relationship and network outreach to Boston Medical Center and really, in essence, generate the revenue that we've been missing as a result of the inadequacies of our referral process. And I'm sure many of you on the call are familiar with those inadequacies within your own systems. In light of today's economics, this has really provided our senior leadership, our CFO, and others who are very interested in the revenue stream of the hospital a real good idea of how IT and technology, and particularly the information exchange, or health information exchange, how that can really be of benefit to business solutions as it relates to revenue. So that's really what I'm going to talk about in today's presentation overall, the information exchange, as well as more sort of focus on the referral portal and the referral process management that we put into place at BMC. BMC is a 626-bed academic facility. So we're located in the heart of Boston and largest sort of level 1 trauma center in New England. It's affiliated with Boston University School of Medicine. Just to give you an idea of what the landscape of Boston Medical Center's network is, this slide sort of shows the community health centers and Boston Medical Center in terms of surrounding the greater Boston area. We call it and consider it an integrated delivery network because we do share patients and we share physicians, but really we don't own any of the community health centers. We are essentially bound to each other by our patients and by the fact that we share some of the physicians, as well as the technology that we've deployed. And as you can see here, we've deployed a sort of a smorgasbord of EMRs out there in the community. The majority of it is GE centricity, but there are others that are part of it. At Boston Medical Center alone, we've got 3 electronic health records that we have to deal with and manage. So we are all digitized. In fact, this week, the last is being deployed in terms of an EMR, and we're very excited about that. So all 15 community health centers will be digitized. But that doesn't necessarily, as many of you know, solve the issue of interoperability. That's really our goal for integrated delivery network that we have, that we call Boston HealthNet, and that is to create a community of care based on the patient. So really looking towards a patient-centric model to be able to have comprehensive information or access to comprehensive information, one patient, one record type of paradigm, but also to enhance and create a community of collaboration such that we can really exchange information with our stakeholders, with our clinician partners, and really provide access to that information seamlessly for the sort of what I call quality continuity for the patient, so that wherever the patient goes, they have the exact same level of treatment and the potential for being treated comprehensively because of the access to information that we can provide to them through our network. And so that's really the goal of our community of care. So we've got sort of a siloed approach, and we are very digitized at this point. So the problem that we've encountered is how do we exchange that information? So yes, we've got HL7 interfaces, but as many of you know, that doesn't necessarily provide interoperability. Almost 3 years ago now, we decided to go down the path of creating what we call the Community Information Exchange, really a health information exchange. And we funded it with grants, like many other RIOs and HIEs have. And we really followed the basic principles of building our CIE, our HIE, with respect to the IHE and HITSP standards. At that point in time, we started with 13, but now we're moving on to the remaining 2. And our vendor for the information exchange is GE. We actually partnered with GE to help build what they now market as their HIE. We've made sure that we had built an HIE with them that was really agnostic to the EMR, because as I mentioned, and I showed you in the other slide, we had other EMRs that were part of our community. And then CareFX, of course, is the e-referral portal vendor that we have been working with, and who developed the portal for us using their native capabilities and their out-of-the-box portal products. One thing that I'd like to highlight here is the funding piece. While we were funded by grants to start, our sort of intent was to really have BMC fund this for our community. And so that is a sustainability issue with regards to funding. And of course, our leadership and our CFO put up the red flags and said, well, we certainly can't put this bill for the community. But I think what we had shown them, at least with this first project, is that if we put this platform together, we have the ability to exchange information, and we can look beyond just pure information exchange, and there are functional applications that we can develop that will really create that community of care and really bring more volume, more partnership, and align the physicians in our community with Boston Medical Center because of that need to collaborate, because of that need to really exchange information. And so that's really what I'm going to talk about here with regards to the referral portal. So beyond the referral management piece itself, it's really showing, and you'll see, the value of this information exchange and what other things you can do with such a platform. If you're familiar with Meaningful Use at this point, or maybe not so familiar because it continues to change, but the idea is that at its core, there are requirements with regards to exchanging clinical information through health information exchange. And so, of course, this is certainly one major driver for senior leadership to support a health information exchange, but oftentimes it's not the only thing that they'll look to fund such a platform that in many ways they're not able to really sort of see and touch and feel. So there are other things that we really need to bring forward to them that they can see something that's tangible and something that's really hitting the bottom line, such as what we'll get into in terms of the e-referral portal system. For sustaining the CIE, we're really sort of encapsulated in what I would consider 4 points. The first is obviously to look at the HIE and use it as a foundation for more what I call value-added applications. So not just sort of the static exchange of information, which really is the basic characteristics of the information exchange. We're really seeing it as more of a platform that enables the use of that data now that it's what I consider liquid information. It's standardized, it's centralized, and it's able to be accessed. So now you got to create applications that really provide value to the organization or the enterprise. Identify business critical processes that require information exchange at its core. And so that's really where we landed on the referral system. We realized that the referral issue was really sort of centered around the inability for us to exchange information and really gather that information for use across the continuum of care and really create benefits to the organization while building the information exchange incrementally. All of this really sort of enhancing and using the current IT investments that we've already put into place and packaging it up to users in such a way where they see the usability, they see the value of the investment. So the bottom line is really, in order for us to show that the information exchange is valuable and to be able to sustain it with funding, we really needed to develop functional applications that address business problems that's supported by the HIE. Because again, the HIE itself is an intangible platform, the back end that nobody really sort of touches and feels, but instantiate it in a more phenotypic application, then folks can see the true value of that back end information exchange. This quick roadmap of Boston Medical Centers as it relates to the information exchange so that you kind of see where we're heading with this. But really, the initial phase of the information exchange was really to get our stakeholders to be able to collaborate, to begin to collaborate and exchange data for the value and the benefit of our patients. And so the first phase of our information exchange lifecycle was really to just create the information exchange. We actually exchanged meds, problems, allergies, lab results, consult notes, getting to exchange discharge summaries and H&Ps and ED notes. But that was sort of the initial foundation an initial build that we put in place. We've also begun to look at developing what I consider a services layer around the information exchange to expose that data, such that we can begin to build very quickly applications like the e-referral application that we've built with CareFX. This way, we can begin to create a platform that is not very different from what we see today in the App Store or in the BlackBerry store, where developers are really sort of beginning to build applications for their niches or for specific purposes. And so as we encapsulate services that really manipulate or actually utilize the data that's now liquid and accessible from the CIE, we can begin to create applications such as the e-referral system very quickly. And we've begun to see the value of this type of architecture as we begin to build other applications on top of our current environment. So e-referrals is certainly the one that we're going to talk about today, and that's sort of the first major application that we've built. But there are further applications and functionalities that I'm not necessarily going to perseverate on here, but certainly are things that can be built and will benefit the organization and the community as we build them on top of this. So things like information reconciliation, otherwise known as MedRec, or problem reconciliation, care management applications, registries, medical homes, surveillance. All of these things require data comprehensively from the community, and we're going to begin to build that into our sort of utility belt or our application portfolio to begin to fill in the gaps that our legacy systems can't. So ultimately, I'm going to serve this up to our users in a portal, and I'll show you the e-referral portal, but there are other applications in this ring, this ecosystem that one would like to present in a physician portal or a patient portal ultimately. And that's how we would instantiate that and serve it up to our users ultimately. So that's kind of just to give you a high-level sort of idea of what our trajectory is. And this is really sort of the drum that we're going to be marching into. The e-referral system really solves the problem that you see here on your screen right. That shows you one quadrant of our referral process before the e-referral system actually was put into place. So this is one of 4 quadrants. The real objective of this slide is to show you sort of the number of things and connections that community health center would have to go through to be able to refer a patient to BMC. So clearly a very disintegrated and manually intense process. And really it impacted the way that we cared for our patients. It decreased the quality of care for our patients because in many ways we couldn't give our specialists comprehensive information at the time of care. Referral coordinators were not able to coordinate the care for these patients in a standardized and more timely manner. And we couldn't actually track these referrals as they went between the community health centers and BMC because we didn't have an electronic system in place to be able to capture that and report on it. And as you'll see, in terms of access to care, we did a very poor job of ensuring that our patients were actually getting to the specialist because there was no tracking mechanism, because referral coordinators and physicians didn't quite know where in the life cycle of the referral process did that patient really fall. And so we actually lost a number of referrals, a large percentage of referrals, because we didn't have the ability, again, to track that patient as they were referred through there. So addressing this challenge was really to create a platform that utilized our information exchange product that integrates with the physician's current workflow without impacting the physician adversely. We already have a lot of things that they're doing on the EMR, and certainly we didn't want to add to that. One that also optimizes the workflow of the referral coordinators, and we found that was part of the issue, is that the workflow was not standardized, nor was it very well managed. In other words, they didn't have a checklist of things that they needed to do, and oftentimes they would drop specific steps. And it also, we wanted to make sure that we enhanced the communication between the PCP and the specialist, the collaboration, if you will. Of course, we wanted to be able to track the referrals, as I mentioned. Finally, to really sort of enhance and make efficient the referral process. And so what we came up with is really a more simplified referral process that at the heart of it really utilizes the information exchange. And so if you go from left to right here, what you'll see is that the PCP at the CHC side really utilizes the current workflow that they have in terms of ordering the referral order to BMC. It doesn't change the workflow at all. the system itself interacts differently because it now sends information to the information exchange to our CIE, and that CIE interacts with a front-end portal that you see up on top there, where the referral coordinator and the specialist coordinator really begin to do the management and the exchange of the referral order as required. And so the collaboration now happens very seamlessly through this front-end portal, and I consider that sort of the initial referral component of the cycle. On the latter end, in the BMC side, what you'll see is that, again, the physician, as they receive the patient from the community health center, they'll now get information from the information exchange, which includes the referral order as well as the clinical summaries that were pushed into the information exchange. So that includes what meds the patient is on, what labs perhaps that were drawn, or any results or procedures that were done to that patient when they were at the CHC. So there's now access to that information, whereas before we relied on more of a paper-based information exchange. This is the physician in the EMR drawing from the information exchange and capturing information on the referral through their EMR. As a result of this, the physician then completes their workup of the patient, and a response is now able to be pushed back to the CHC in an electronic fashion. So whereas before, the BMC would complete the visit with the patient, but oftentimes we wouldn't do a very good job of sending the PCP who referred that physician, that patient to, or that these are the things that we see required for continued care or care management. And so now here, what happens is there's an actual automated response that happens that is actually managed by the referral system in conjunction with the information exchange. And so essentially, if you think about what happens in the back end, the BMC specialist will complete the visit. We'll go into the CIE. The CIE and the e-referral portal will communicate to the community health center's EMR and basically ping the PCP, the originating provider, and say, the referral is done, here's information that you can access from the information exchange. And that's part of the referral system that we've put into place. And so it's a very seamless response. So, and then finally, the whole system, since it's digitized, as I mentioned, is now trackable. So we're able to actually, again, solve, instantiate the referral cycle in what I consider refer, respond, report life cycle. So this is something that has been problematic for Boston Medical Center, but now with this system, we're able to do and manage this cycle in a more digitized electronic fashion, which has really provided us with a tremendous amount of benefit. So the e-referral portal itself is actually a product that CareFX had actually customized for us. They built it on IBM WebSphere, used their Fusion FX components. And one of the main reasons why, in addition to the fact that we were able to customize the referral portal, one of the main reasons why we also wanted them is because of the fact that they could leverage our information exchange, and we thought that that was a very novel use of our HIE. And also they've got many ways to integrate with it, the EMRs that we have in place. And so ultimately what we created was a portal that worked for BMC using, sort of the native components of what Fusion FX and CareFX already has under their belt. And so I found some photos or images of the CareFX new referral portal as customized by BMC or for BMC. And so really what this is actually just a work list for our referral coordinators. And this really takes all of the referrals that they manage on a daily basis, of which there could be hundreds, and puts it in a referral work list that really enables them to manage and identify those referrals that need to be addressed or those that are in process and so forth. So now they have one single place where they can manage all of their referrals. And this is where they also collaborate with among referral and specialty coordinators. This is just a screenshot of the insurance information that they might begin to gather. And much of this gets pre-populated. If it doesn't get pre-populated, they can actually go to the links that either the insurers or our centralized payer database for New England can provide. And so we have ways to automate the authorization process for the coordinators. And one thing actually I'd like for you to focus on is if you look in the middle there, it's a little blurry, but there's a referral checklist. And what that is really sort of like a TurboTax type of paradigm where we create a workflow, specific workflow for our referral coordinators and specialty coordinators so that they know what part of the process they are supposed to be and what they're supposed to be doing, because we don't want to drop any of the steps. In fact, when we first rolled this out, some of the coordinators, the referral coordinators, were complaining, saying, I thought this was supposed to make my life easier, but it turns out that it's making me do more work. As we investigated further, what we realized was that they were feeling like they were doing more work because actually they were doing the work that they were supposed to do. So in other words, they were missing steps prior to the implementation, but now we're ensuring that they're meeting all of those steps and all those requirements to getting a referral process, such as things like prior authorization. Of course, we want to get paid, so we have to get that resolved and dealt with. The screenshot here is really looking at the information exchange. So the portal itself actually goes into the information exchange and shows the coordinator the documents that are available for that patient, and can attach any of the documents as a link to the referral order. There's also a set of management reports on the referral portal that were developed for us and that were customized for our needs. But I think that they're pretty generic in terms of what folks would want to see if we were tracking this referral process. And so things like referral volumes, we've never had a chance to really track the referral volumes that we were getting from community health centers in the past, because again, it was paper-based. Now it's digitized. We're able to track referral volumes by organization, by provider, get to the point where we're breaking it out into the disease states, et cetera. Certainly tracking efficiency is a big deal for us. We want to make sure that we're responding to our customers timely, and also making sure that we don't drop the ball in terms of scheduling for patients who are looking for access to care or access to an appointment with one of our specialists. So certainly this is a way for us to track the way that we respond to referral orders. Of course, tracking outcomes, making sure that we can identify no-shows and we can try to correct those, reschedule them, if you will, or any sort of procedures that sort of result. Were they duplicative procedures or were they appropriate? So we're able to now figure out from a referral what are the things that were done for that particular patient or patient population. Our leadership is very interested in leakage, tracking leakage. One would think that an integrated delivery network would assume that most stay within your network, but of course we've got a lot of other hospitals here in Boston and surrounding areas, and so there's a lot of good data to try to figure out why one might go elsewhere than instead of staying within our community health center facility or within Boston Medical Center. So this type of leakage tracking is certainly very useful for management and understanding just whether or not our services are adequate or appropriate or what folks feel is missing. And then, of course, tracking compliance. Do we get the actual prior authorization for the visit and so forth. So these management reports are available for all types of users, but mostly utilized by our senior management as well as our clinicians who are interested. What you'll see is really sort of the impact of the portal to date. It's sort of in two segments. One is the satisfaction impact. Because of the comprehensive information accessibility that we've now provided through the information exchange, and then sort of wrapping that with the referral process, we've really created satisfaction with the coordinators themselves, the physicians who are referring, as well as the specialists that are receiving, and then, of course, the patients. Particularly for the physicians, I think there was a lot of frustration with information being exchanged, and now that we're able to exchange digital information through the portal, through the information exchange seamlessly into the EMR, they're able to now know and identify a patient who's coming to their facility and say, now I know why you're here, versus in the past, we'd have cases where patients would get referred to BMC, information would get lost in transit, and folks would just not know, physicians would just not know what they're being seen for or why they're actually there, and we would end up having to redo procedures or tests and so forth. But now I think we're seeing really the benefit and the value of having that information exchange and that referral management process in place. For the patient, I think what we're finding is that they're accessing care much more efficiently, they're getting more timely appointments, and they're really just much more satisfied with the fact that they're not feeling like they're the ones that are really burdened with calling the receptionist and saying, hey, did you schedule that appointment yet, so forth, because now we're actually on our end managing that and understanding what is missing and what's really sort of available from a scheduling standpoint. In terms of the revenue impact itself, what we've seen in scheduling of referrals, before the referral portal was put into place, what we had seen is that we were only scheduling 30% of those referrals that were actually ordered. After the e-referral management portal was put into place, what we were seeing was that we've increased our catchment of those orders by 30 to 50%. So we're around the 60 to 80% range. It almost seems illogical, but what was happening again was that we were getting referrals ordered and they were getting lost, like through voicemail or through fax and those types of things. And so there wasn't an understanding of who really had the ball at that time. And a lot of referrals were getting lost. 70% of referrals that were ordered were getting lost. That's a lot of revenue. So we're now seeing that on average we're upwards of around 60% or so in terms of catching those referrals that are ordered and scheduling them. In terms of turnaround, scheduling appointments as they're ordered used to be as sort of on average 33 days, sometimes even much more than that, sometimes upwards of 60 days to actually schedule an appointment. Now it's between 6 to 8 days. So again, we're seeing more efficient, more timely turnarounds with regards to scheduling. No-show rates are also sort of looking better. So before, of the 30% that we would book, we would see 25% actually not show up. So not only did we lose 70%, we were also losing within that 30% another 25% because folks weren't showing up. We're continuing to decrease that. We're down to like 23%, maybe a little bit less. Obviously, our trajectory is to bring it down to zero, probably an impossibility, but we're looking for incremental improvement. So 20% is our goal, and I think with some more work and some more training, we can get it down to that. Right now, we're around 23%, and that's still actually a pretty good improvement, particularly as I mentioned, the catchment of referrals scheduled is now up to 60 to 80%. That's a big improvement. In terms of the referrals themselves and improvement over time, what you'll see here is that this is the referral order to schedule graph. And basically what this is showing is that the number of days, the start of our implementation, was upwards of 65 or so days in terms of the referral order. Over time, as we've implemented this and really folks have begun to use the referral system, it's really sort of come down to an average of around 8 days, which is really tremendous. And so, again, the turnaround for us to schedule a referral order has really increased significantly. The percentage of scheduled referral orders, as I mentioned before, the e-referral system, we were at 30%. Of those referrals that were ordered, we were scheduling only 30%. What we're seeing now is that we're sustaining a fairly decent percentage of referral orders scheduled, so we're around the 60 to 80 mark, if you will. Obviously, we'd like to be at the 100% level, and we're working towards that. Our ability to complete documentation, and so this is only 3 departments, but what you're seeing is the right trajectory, which is increasing the number of days for us to complete documentation to return back to the original referring provider. And that's really, that a lot has to do with the relationship development, in many ways satisfaction for our PCPs who are referring to BMC. We certainly want to respond to them. We want to communicate with them, and to provide them with little information or very sort of delayed information is certainly not our intent. This process has really provided us with the ability to improve that communication and that response rate to our referring providers. What you'll see is, again, the timeliness in terms of referral order request to the actual visit. We're seeing even increases there from a referral order to the patient at the doorstep. It's really, I think, providing that type of efficiency again and making sure that we're providing access to care for our patients optimally. Just a bunch of satisfaction comments from our community. The last bullet there is really sort of kind of encapsulates it all. They really wanted us to expand this to BMC ASAP. We started this process or project really with just the Department of Medicine to see if a pilot such as that would really translate well, and it really was a successful pilot, and so we've begun to expand that. Actually, we're almost done expanding it. By the end of this month, we'll have finished expanding it to Boston Medical Center as a whole. See here is really the ROI. We had IBM come in and really do a business process analysis, take a look at our current state, and then look at the to-be state with the e-referral system in place. What they estimated was that if we were to decrease our retro rate to 20%, from 25 to 20%, and increase our catchment from 30% to 50%, and as I mentioned, we were now at 60 to 80%, we would see just by increased referral throughput alone and also reduction of operational costs, because the cumbersome process was really taking up a lot of time for our coordinators, we'd see roughly an ROI of about $7 million in a single year once the application was actually up and running. And paired with the actual investment that we put in, which was largely grant funded, but then we put in our own sort of personnel investment, we would see roughly around a 500% ROI. If you look at the math and you look at the analysis, it doesn't seem so far-fetched. And what we're seeing now is that we're getting really close to seeing these types of numbers really become a reality. We just, like I said, as I mentioned, we're just really completing the implementation of it throughout Boston Medical Center, because we started with the Department of Medicine only. Now we've really expanded it to the other specialty departments. And from our analysis, we believe that next year we'll be seeing these types of numbers really become a reality for Boston Medical Center. But we are seeing an increase in referrals being scheduled, referrals coming through the door because of our new process. The next slide is really sort of the physician impact. As I mentioned before, developing the system really for us was to make sure that we provided, that we didn't give any or make any adverse impact to the physicians, allow them to sort of sustain their current workflow, but really ultimately give them comprehensive information pre and post the referral, and also be able to track their patients as they go through the referral process. If anyone's interested, that link here is actually a link to Dr. Dan Newman, our CMIO's interview with CareFX, and his perception on the e-referral portal itself, as well as our information exchange. So if you just go to CareFX's website, you'll see his video there. He shot it at him, so there's a lot of background noise, but you can hear his response and the value proposition that he sees from the e-referral portal itself. So the next steps for us, as I mentioned, is to really sort of complete this rollout to BMC, which we're going to be completing by the end of this month, which is exciting for the community health centers because now they'll have access to all of our specialty departments. But then we want to also expand this within BMC. So right now this is actually just from our community providers to BMC. We're going to plan to roll this out within BMC, so that means that our primary care physicians can now use this system as a way of ordering consults or referrals to our specialty department. So it'll be intra-BMC, not necessarily just sort of inter-BMC or between the community health centers and BMC. And we believe this is going to enable us to actually do a lot of the things that we've done with the community health centers, including tracking, and most particularly track any leakage that comes out of BMC. Our new CEO came from the Brigham. One of the appalling things that she's seen at BMC was that we have a good number of referral leakage outside of BMC. And I was talking about the community health center leakage, but this one is actually within the four walls of Boston Medical Center. We asked her, well, how did you deal with it at the Brigham? And she said, well, this was never really an issue that we had to deal with. So she was quite surprised with that. But I think with the expansion of this into BMC, we're going to be able to track that type of referral leakage and then begin to address, well, what's really sort of at core the issue there, and how can we continue to sustain the business within our four walls rather than have it lost to Shield MRI or something of that nature. And then finally, expand this more broadly than our community only. We actually get referrals from physicians who are outside of our greater Boston community, small practices in the South Shore or even community hospitals in surrounding areas. And so we want to present this referral system through our external website and enable those referring partners the ability to track their patients and get access to information through the information exchange in a slightly different way, because they won't necessarily interact with their EMR, but they'll get it through the extranet. We would plug this in very similarly to how sort of FedEx plugs in their tracking system. It would be through our website, and CareFX is working on that for us, and that should be an exciting addition to our referral system capabilities and referral tracking and management capabilities. And certainly it's something that we're looking forward to because it will continue to develop our network beyond our community. So, in summary, the referral problem for us was really solved by this e-referral portal, and it really managed to deal with three major issues. One was obviously this revenue loss that we were seeing with regards to the fallible process that we had for referrals. And then two was obviously an impact on the patient themselves accessing care in a seamless way. So we now ensure that we can get the patients through the door, and if we don't, then we can at least track them and identify who they are and why they didn't show up for the appointment, but certainly manage that no-show rate and manage the reschedule rate and identify which patients we need to really follow up with. So access to care was really, truly something that we wanted to enhance. And for the physicians and those in the community, it was really information accessibility. And our information exchange, the CIE, which really sort of is the foundation for our referral portal, really provided that capability that we didn't have in the past in a more digitized fashion. And so really what we saw was an improvement that was even broader than just solving the referral problem. But again, it really sort of impacted the way that we treated our patients, our use of our information systems, and it provided our senior leadership the ability to sort of see tangible impact to the bottom line, in that we were able to really provide an ROI very quickly that showed the value of the application and the technology that we were putting into place. As a result, the portal itself has been a very impactful and a large topic of many conversations at BMC because of the high satisfaction from our customers and our users, as well as the satisfaction to our leadership, who is seeing a lot of impact with regards to, again, our revenue. So with that, I'll take some questions. If there are questions out there, certainly would be interested in hearing your feedback. Others have been trying to do a very similar or solve a very similar problem. Would love to hear some feedback from you folks. But that's really the end of my presentation, so thank you.
Question or comment?
Hi, I have a question about if you can expand a little bit about how the information referrals get integrated into the EMRs directly. Is that, is the information put in as a note, or is it some sort of a standard format? Can you expand on that a little bit?
Yeah, sure, absolutely. Thank you. So that was actually one of the reasons why we wanted to piggyback on the information exchange, because we really had two objectives. One was we wanted to have the physician have the capability to view the referral order and the actual results using a CCD. So if they didn't necessarily want to bring it into their EMR immediately, they could at least view it as a CCD document. So the CCD would be just a single document, clinical summary. And there's an automatic transaction that actually happens once the referral is completed. So the referral system creates a trigger and an alert to the receiving EMR saying, hey, the referral that you had sent out through the portal has been completed. And so if you wish to view it, go to your EMR and view the CCD document. In terms of importing it into the EMR, it then becomes a process where they select the CCD document and an encounter form. We use, many of our users use Centricity EMR or Logician. So an encounter form comes up, and they're able to select the segments of the clinical summary that they wish to import. So if they wanted to import meds from the specialist visit or lab results or what have you, they would be able to select those, and those would then be imported in directly to their EMR.
Okay, so the CCD is available as the method to be able to import it into the EMR.
That's exactly right. That's basically the basis for our interoperability for the referrals. So both the orders and the clinical summaries at the specialist level are instantiated into a CCD document that then could be imported to the local EMR as they wish.
Okay, thank you.
You're welcome.
Other questions?
How many staff do you have that handle the referrals coming in? And I'm assuming just from the outside, and they don't overlap and handle internal referrals.
Right. So we actually, at BMC, we don't have a centralized referral group, a central referral group.
Okay.
And so that was the first problem that we saw, was that we just, we had folks sort of filling in. We had admins doing this work. We had, and folks that weren't necessarily skilled to do this type of, service work, customer service work, and collaboration. With the tool, we were able to really, identify individuals who could use this tool and really sort of be trained on the fly because it was so intuitive. So we still don't have a centralized group, but we've got folks who are identified for each of the specialty practices, and admins, and some actually that are referral coordinators, and they're able to really manage this workflow. At the community health center level, they actually have referral coordinators specific to this practice or to this process. Some of them have found that they can now, instead of use 3 or 4, they can sort of decrease it to 2 or 3. So they've begun to see efficiencies there. And some of the people that they'd used for referrals originally were nurses, so they were able to get back to the floors and not have to deal with this type of referral process. So I think over time we'll see it dwindle even further because the process seems to be more efficient, and folks are really understanding now the workflow. And so we believe that really we can pare down the coordinators to a minimal number that will free up others to do other things.
Any other questions?
My question is the actual user interface, the screens that are used by the folks sending referrals and receiving referrals, those were all developed by staff at BMC, or did a vendor do that work for you?
So, thank you for that question. That was actually, so CareFX helped us develop the front-end application for this. So as I mentioned, they have a referral product that they offer, but we had some needs on our end that we needed to satisfy with regards to Medicare and so forth. So there were some customizations that we needed to deploy. And so CareFX uses IBM WebSphere as their foundation for their portal. And we basically developed alongside of CareFX the requirements that we had, and that translated into functional design, and then it resulted in that front end that you see there. But again, the guts have already been created by CareFX, which is a vendor, and we just helped customize it for BMC specifically. Does that answer your question?
You already owned the network infrastructure to run all this on, or you purchased it as part of your startup cost?
So we already own the information exchange, the CIE, so that wasn't part of the startup cost. The startup cost with respect to CareFX was really getting a license for WebSphere, IBM WebSphere, and then getting the servers that would house the portal application, all of which was really provided to us in the form of a spec by CareFX. And so ultimately, what we ended up providing, in addition to the capital costs of the servers, was staff and staff time to try to design the process and the workflow.
Very fascinating.
Thank you.
Very fascinating. In Western New York, we have kind of split our health information exchange into 2 parts, one being the administrative side, which is things like authorizations and referrals and eligibility and those kinds of traditionally financial transactions. And on the other side, we have a clinical exchange, which is more the CCD documents, the orders, the medications, and that piece of it. What I really hear in this is a completely dual purpose. There is both the clinical side of a referral and the administrative side of a referral, both happening in the same space.
That's right. Yeah, and actually, in many ways, we're running a very similar paradigm to what you've just described, because there's, as I mentioned, there was one page where our coordinators would hit up against our sort of the payer database, which actually is run by our Massachusetts RIO. So our Mass RIO is mostly the administrative pieces. It's called MEHAN. It's our sort of payer / authorization information exchange, but we don't have a clinical component to that. So the clinical exchange is really the one that I built with my community. This portal basically integrates both of those, such that now they being the coordinators and whoever else is a stakeholder, this just needs to go to one place. and access all of those simultaneously. And then we manage the clinical components of it primarily because that's in many ways what the core issue was that we had found with regards to information exchange for our clinicians. Now, do you guys have a portal? Do you guys have sort of a referral management process that you have already created, or?
Well, we have the financial referral process, which is obviously the payer authorizations of a referral to a specialist for our managed care covered lives, right? So we have that going in a web-based portal, community-wide solution, and completely separate from that, we have some clinical exchange, but they're not, the two solutions don't dovetail.
Right.
Does that make sense?
Yeah, it does. It does. Yeah, and so that's what we were trying to attempt to do here was really put those pieces together, and that works for us. So I'm sure that you probably have some complexities that we don't necessarily address, but again, it's something that we customize this for our needs, at least both our administrative and our clinical needs. But it was easy enough as long as we were able to create the workflow. The functional instantiation of that seemed fairly easy to deploy on this portal. And, when we developed this portal, we did fund this with a grant initially, and the grant stipulated that we needed to really finish this within 12 months, or really it was 6 months, because we needed a report 6 months post deployment. I don't know what they were thinking, because we all know that creating an application it takes a lot longer than 6 to 12 months. But with this product, we were actually able to hit that time frame, and CareFX was able to do it much more quickly than 6 months. We actually were sort of the limiting factor for them, and GE was a limiting factor for them. So it took them just roughly 6 months to complete this, but I think they probably could have completed it much more quickly, and the workflows much more quickly. Because again, they had all of the guts already in place. It was just a matter of really, hooking it up to information exchange, and then creating the specific workflows and functions that really were required by the business, both from a clinical and administrative perspective.
Do you have a lot of physicians that use the e-referral portal, or do they rely on the EMR for notification?
Yeah, they, we sort of did that by design. They rely mostly on the EMR for notification. So they today, actually even before we put the e-referral system in place, they were placing the referral orders in the EMR, but then they were printing out the referral order and then faxing it. And so here, in this paradigm now, what they do is they put the referral order as they have done in the past, but are no longer printing out the referral order. They can view it through their EMR as they ping the health information exchange, and they can see the order that way. Or they can certainly print it out of the portal if they wanted to log in. What the clinicians are interested in now is really using the portal to manage their panels and see where folks are within the life cycle of the referral. Did this person get a scheduled visit? Did they actually show up to the visit? Did all of my patients who have month actually make it to their visits, or did they get scheduled? So now they're looking more for the management perspective of it from that angle, and so yeah, they're certainly still managing the referrals or the order within the EMR as they have done, but the requirements have changed because now they've got more of a digitized set of data for managing those referrals.
And do you integrate with your scheduling system to get updates, or is that manual of appointments, no-shows, bumps, anything like that?
Yeah, it was actually that was something that we wanted to put into place, and we're still looking to do that. The issue was more cultural than anything. Our specialty organizations had a very difficult time opening up their schedules, feeling like they were losing control of it. So we've been discussing sort of that requirement and that need, and so we're moving towards that. And once they've agreed to really opening up their schedule, I think that integration is more likely and more possible. So at the moment, we don't have it integrated with our schedule system. But I think it's not a technology issue; it's more of a cultural issue.
So when a visit is flagged as complete, is that manual as well, or is that because the specialist wrote the note?
Yeah, so the trigger is that the specialist wrote the note, and then the specialist coordinator can decide to close it. That's the way that the practice, that's the way the clinic wants to have it closed. And then basically it goes through the e-referral system, and the e-referral system interacts with our interface engine, which then puts a flag into the EMR and says that this is complete. And now you can look in the CIE or the HIE for the complete documentation. So it's an automated process, really, as a trigger, as a result of the trigger of the specialist completing the documentation.
There must be fields within the documentation that link it to that referral somehow?
Yeah, actually, the referral is linked by a referral order that's generated out of the EMR into the e-referral portal. So, in other words, that's part of the reason why we use the CIE also, or the information exchange, is because we're able to identify both the patient and the order and really match them up and link them up as they go through the process. So there's I wish I could show you the graph or the chart, but there's really an identification process that happens as the referral order is pushed out of the EMR, and then that's matched to anything that happens to that patient during the course of their life cycle. Because that was an initial problem that we had to address, because as you can imagine, there could be 5 referrals for a specific patient, and how do you know which referral and the result of which referral goes to which of the referrals in the management process. But that's addressed by unique identifiers that are attached to each referral order that gets spit out of the EMRs and gets integrated into the e-referral portal. So the portal does a lot of that management and that identification and linkage. I guess that's one of the benefits of having it.
Joel, this would seem to give you a leg up on establishing yourself as the medical home for these patients and or getting into the business of being an accountable care organization. Have you had discussions along those lines with your payers, and do they see this direction that you're taking as part of some of those opportunities?
That's a great question, and we actually haven't yet discussed it with our payers. We're mostly Medicare and Medicaid based, but in terms of the medical home, many of our physician leaders are certainly interested in that, and this certainly satisfies the sort of the tracking and the coordination of care component of the medical home. And so this referral capability, the tracking of the referrals, is really, I think, a large part of getting to a higher level of medical home certification, I guess, if you will, for our clinicians. And so, yeah, I think this is one of the things that our community health centers were excited about, because it really sort of gives them a check against that requirement of being able to track and coordinate care across the community.
And refresh my memory, but the community health centers are not owned by BMC?
That's right. They're not owned by BMC. We share patients and physicians, and so this process is really in many ways a voluntary process for them. But they want so much to have an easy way to refer to BMC, and we've in the past not made it easy for them, as I showed you in one of the slides. But now this is really for them a very easy process, and so yeah, it's really shown benefits for them in terms of efficiency. But yeah, we're in this together, but we don't own them.
And then you mentioned rolling this out to non-affiliated health centers. What would be the additional hurdles then that you would have to face with that particular group?
Yeah, I think that in discussions with CareFX, at least, I think that's going to be a little bit easier now that we've kind of gone through most of the workflows with our providers internally in our community. The objective for expanding this to non-affiliated non-affiliated or non-sort of network organizations is really just to provide kind of the tracking tool, which we already have, to those providers, to those organizations. And so, that we'd have to create a way for them to securely log into our extranet or our website. But then once they're there, they can identify the patients that they're looking for or they're tracking, and basically we'll just show a status. And then if there's a CCD document that's available to be accessed, then they can do that. But the idea would be to just at least know if Joel Venko was being seen or has been seen or was a no-show, and then if his visit has been completed, what documents are available. It's not our objective to integrate it with their EMR, so they would have to actively go into the website to access that information. But that's leagues better than what we have today, which is really no way of providing them an understanding or a view into how their patient is being cared for at Boston Medical Center.